All right, I think we'll go ahead and get started. I'd like to welcome everyone to a new initiative from the World Federation of Hemophilia, and it's practical education on bleeding disorders, knowledge for all. We decided several months ago to initiate this, this type of a webinar series. We're doing 4 of them this year as an effort to take advantage of a lot of the new research, new initiatives that are ongoing within the WFH on better treatment methods, new improved ways of managing patients, all in an effort to continue to communicate globally, especially in this time when we have travel completely eliminated at this point. And so it's an opportunity for us to exchange information and to stay current on many of the initiatives that are occurring within the global hemophilia community, which includes all bleeding disorders as well. So this is the initiation of the series. We are going to be running 4 of them this year. This is the initiation of the series. We're initiating 4 of them this year. And on behalf of all of my colleagues that are online with me, I'd like to welcome you to the series. I'm Glenn Pierce. I'm the Vice President for Medical for the World Federation of Hemophilia. Next slide, please. This is the translation information. So you've got an interpretation button that allows you to pick a language to be able to hear the presentation in a more native language. And then we also have a Q&A button. Please use that to ask questions, and then we'll cover the questions at the end of each session. Next slide, please. For mobile phones, we've got instructions for both Android as well as iPhone. So if you take a look at this, you can see the 3 dots that will allow you to select your interpretation channel. Here's our agenda. We'll cover a number of timely topics and divide that up into 2 Q&A sessions. And so each of these are going to be 15-minute talks given by experts in the field. Next slide, please. On behalf of my co-moderator, Marlene, I'd like to welcome you. Marlene will be handling the second half of the webinar. Next slide, please. So our first 3 speakers include the gentlemen that are listed here, and I'll introduce all of them now, and then we'll go ahead and then have it run in a continuous way. So our first speaker is going to be Cedric Hermans, and he currently heads the Division of Hematology, the Hemostasis and Thrombosis Unit, as well as the Hemophilia Center at the St. Luc University Hospital in Brussels, Belgium. Cedric has co-authored many articles. He's been president of EHAD, currently a member of the board of directors for the World Federation of Hemophilia, and is the editor-in-chief for the Hemophilia Journal. Our next speaker will be Gianluigi Pasta, and he's an orthopedic surgeon and in the of emergency traumatology department and rare disease orthopedic surgery at the Foundation IRCCS La Granada Ospedale Maggiore. Wow, I'm really butchering this one. In any event, he's in Milan at the hospital there, the main hospital there, which is a premier hemophilia treatment center. And Gianluigi is the chair of the WFH Musculoskeletal Committee. He's also active with the Italian Hemophilia Centers Association and is been very active in giving talks around the world on methods of orthopedic surgery for hemophilia. And then our final speaker here is well known to many of us for a long time, Sukesh Nair. He's a professor of laboratory hematology at the Christian Medical College in Vellore, located in South India. and he's the scientific coordinator of our IAQUIS program. It's a program that provides for quality assurance testing for over 700 labs for lab testing. And he volunteers a lot of time, giving a lot of talks. He's done many wet labs in the past to teach coagulation assays. And he's the immediate past chair of our WFH IAQUIS committee. So with that, we will move on to our first speaker, who will be Cedric. Cedric, the floor is yours.
Thank you, Glenn. Dear colleagues, dear friends around the world, it's a great pleasure to give you this first talk of this educational activity. So I have 15 minutes to tell you what I recommend to do when you run your clinic. So let's say you have 20 minutes to see your patient. Next slide. So here are some disclosures. Next. So I think there are some questions you should ask yourself about your clinics and what happens when you see patient. First of all, how much time do you have per patient? Do you run this clinic alone, or do you run it with a nurse or a physio? Do you adopt a holistic approach of the disease? Do you cover, all what could be related to hemophilia? Do you use electronic records? Are specific modules or dashboards available in these electronic records? What is your main challenge when running this kind of clinic? And also, clearly, do you use telemedicine today in this new COVID era? Next slide. So this is quite difficult to define clearly what you should do during your clinic. And to help physicians, myself and several colleagues and friends from Europe, we wrote this paper a few years ago in Hemophilia. Next slide. When you run your clinic, I think there are several domains that you should be addressed. First of all, you should try to collect baseline information. You should try to update this information. You should collect information about the treatment, the inhibitor status, bleeding status, joint status, comorbidities, dental care, physical activities, social participations, quality of life, and also an important concept of empowerment. You'll tell me, Cedric, this is not possible to do in 20 minutes. Trust me, you can cover a lot of these domains within 20 minutes. Next slide. First of all, it's clear that you should have baseline information available at all time. This is critical, certainly for registries, date of birth, blood group, diagnosis, what type of hemophilia, what severity, when was the diagnosis made, is there a family history, when was the first bleed, at what age, when was the first joint bleed, and when was the first substitution. I think this is important. The mutation, the genetic variant should be identified, as well as the inhibitor status. You should also know the ethnicity, if the patient is on prophylaxis, when was this started, and is there a family history of inhibitors. This is the baseline information that we absolutely need when seeing our patient. Next slide. It's clear that at each clinic, every time you see the patient again, you should update this information. So you should try to know, what's exactly the replacement therapy and what's the kinetics of this replacement therapy, at least some information. If the patient is on daily AVP, you should know or update the response. I think what's also very important to do is to update the family tree at each visit. That's what I do on a regular basis. I try to make sure that all patients with hemophilia have been identified, and certainly all carriers. I also try to know whether new inhibitors have been identified. You also should try to know whether patient developed blood-borne infection, important, vaccination status. What happened since the last visit in terms of major bleeds? For young children, you should try to calculate or be aware of the cumulative exposure. And clearly, if this is a young child, you should make sure that the inhibitor screening has been conducted. Nice. Next slide. What's also quite important is to update the hemostatic treatment information. So what's the currently treatment? Is this a concentrate? Is this a non-factor? What else? If the patient is on prophylaxis or on demand, you should clearly record the treatment modalities as well as the annual consumption. Ideally, every patient should have a logbook, and this logbook is critical. That could be a paper logbook, an electronic logbook, and you should really go through this logbook. You should also try to identify other hemostatic treatments, also hospitalization, other medication, and what's also very important during the clinic, and that does not take much time, try to make sure that patients do understand their treatment, that they are aware of treatment innovation, of treatment alternatives, and also try to know whether patients are motivated or eligible for clinical trials. Next slide. Certainly, at the time of the clinic, you need to collect information on bleeding episodes. This is obvious. This is clearly what we want to prevent with appropriate treatment. And don't forget, the ambition is to have 0 spontaneous joint bleed. And this is what I try to know. If the patient did not bleed since the last visit, this is good news. If the patient kept bleeding, it's not a good news. Next slide. Clearly, you try to collect information about this bleeding episode, what sort of bleed, where this bleeds, major bleeds, minor bleeds, other bleeds. I think this is important to collect this information. Next. Joint health, status, and pain. That will be addressed during the next talk, but I think this is very important. You should try to assess joint function and also pain. Pain, which is a very frequent problem in our patients. So try to know whether the patients have target joints, problem joints, early joint damage. I'm a physician, I'm an hematologist, so clearly to do this properly, I need the support of an expert hemophilia physio specialist or someone who is able to do that, because that could take a little bit more time than 20 minutes. Next slide. Comorbidities. Or adult patients certainly do develop comorbidities, and we should try to identify these problems. So clearly, hepatitis C has been a long problem, is still a problem. So let's make sure that all patients with Hep C have been identified, that the virus has been eradicated. And also we know that long-term treatment and long-term follow-up is important. HIV, for patients who developed HIV in the past. Cardiovascular risk factors or disease, very important. I always measure the blood pressure and make sure that patients do not have major cardiovascular risk factors. Do they have cancer, prostate cancer? Do they have other health problems? Osteoporosis, sexual dysfunctions, obesity, liver problems such as fat liver. So pay attention to that. They should be identified. You could think that the GP, the general practitioner, will do the job for you. I don't think that. You won't have the responsibility of managing all these problems, but make sure that you identify these problems. Next slide. Dental care. This is important too. Make sure that your patient has a good dental hygiene and is regularly followed by the good dentist. I think this is important. When was the last dental assessment? And let's also make sure that the patients do understand what they need to do when they go to the dentist. I think this is also very important information that can be discussed with the patient during the clinic. Doesn't take much time. Next slide. Physical activities. Well, you need to make sure that your patient is physically active. You could use very complex questionnaire to do that, but you could also ask very simple question about sport activities, hobbies, what sort of sport, how frequently, and how do they adapt the treatment to their physical activities. You need to know what they do in terms of occupation and whether this occupation is associated with an increased risk of joint damage. This is important because that could have major impact too. Next slide. Quality of life. So this is also a very important concept. This is kind of information that we need to collect during this busy clinic. So there are many tools that are available. You could ask a few questions about the patient, the quality of his life, his frustration, happiness, whatever. You could also use some questionnaire. There are some very simple questionnaires, such as the EQ5D for adults. So try to do something. It could take time, so maybe the patients won't have time to complete the questionnaire during the clinic, but he could do this in advance or after. Next. Social participation. So try to collect information about this. Education, employment status, marital status, offspring, disability allowances. Also important, the number of days lost from work or school since the last visit. Important information that could really reveal the impact of hemophilia on your daily life. Review of the total days lost annually, very important. And also, try to know whether the patient knows about the local patients organization and is playing an active role in this. Try to know whether the patient knows what the WFH is and invite your patients to get in contact with the WFH or at least visit the WFH website. Next slide. Patients empowerment. I think this is a very important concept. You should try to value each of your clinic to make your patients a better patients who can really get a better control on his disease. To achieve this, the patient should ideally better understand the disease, the treatment, the innovation, accept the disease, interact with the local NMO, know about the activities conducted by the WFH and other organizations, try to know whether the patient is interested in clinical trials. Also, the registries are important. And you certainly know about the WBDR. So try to include your patients in the WBDR. Very important for the future. I'm convinced about this. And try to make sure that your patient is interacting with other patients, because this is very important too. The patient should not feel that this is the only patient with hemophilia on this planet, which is obviously not true. Next. So to conclude, because you could tell me, Cedric, this is too ambitious, I couldn't do this. I think it's possible to collect a lot of information within 20 minutes. But what do you need to do? Well, you need to prepare your clinic. So you need to review the patient's medical records or files the day or a few hours before the clinic. This is important. You also need to identify the priorities. That means the active problems that will require attention during the clinic. And to achieve this, you could always contact the patients before the clinic by phone or email and ask the patients what are the new active problems. Don't forget, you should have a holistic approach of hemophilia, not only focus on the concentrate and the joints. It's a much more complex disease. Value each clinic as a major opportunity to improve understanding of the disease by each patient, level of adherence, and also interaction with the patient association. That's what I try to do during each clinic. Also, don't do this alone. Run your clinics with the nurse and the physio. They will help you and they will try, they'll do their best to value these 20 minutes. And also another concept, what we do in our center, there is no patient's monopoly. What do I mean by this? That all the patients are seen by different doctors at different clinics. And I think this is very important. Patient's monopoly is not good. I think it's nice for the doctors to see other patients, and it's nice for each patient to see different doctors, because all of us, we are different and we need to share our expertise and experience. I think this is my last slide, and I thank you for attention and be happy to take questions at the end. Thank you.
Hello, everybody. Thank you, Cedric. And it's a pleasure for me to be here today, and it's a privilege to share with you this experience. Please, next. What we have to, Cedric already said that, of course, when you have to assess a patient with hemophilia, you need an MSK expert. It's not important if you have a physio, an orthopedic surgeon, a physiatrist, but you need an MSK expert. And the MSK expert has to be multitasking in the field of hemophilia. Please, next. Because it's important, because we have to do prevention. Our goal in hemophilia is to prevent the onset of a hemophilic arthropathy. It's not only to treat. So also as orthopedic surgeon, we have to know that our goal is to make prevention, not to treat deformities. Please, next. And how is it possible to do that? Is it possible if we are able to give answers to some aspect of hemophilic arthropathy about pathogenesis, diagnosis, and treatment? And today we will focus my presentation on diagnosis, what is possible to do in 20 minutes in a patient with hemophilia. Please, next. And the first thing that we have to know, that the first thing that is really important, even in 20 minutes, is listen to the patient. You need to be able to know your patient and the patient has to know you, because especially in the field of a chronic disease, it's really important the relationship that we have as medical doctors with our patient. It's critical when we have to take decision. It's critical when we have to take surgical decision in patient with hemophilia. Please, next. And of course, it's really important to be able to assess. And the assess is important to make diagnosis. It's really important in order to evaluate what you have done to the patient. So of course, as orthopedic surgeon, it's really important to know and to be able to assess our patient, but it's really important in order to follow our patient during years. Please, next. And of course, it's more easy to follow your patient, to assess your patient if you are able to use the same language. And numbers are the same between doctors, between physio, between MSK experts all around the world. So, of course, the availability of a validate scoring system in the clinical assessment is really important. And the hemophilia joint score have represented, of course, something really important in the field of hemophilia. Please, next. But if you think about what is possible to do in 20 minutes, maybe HHS is much more than 20 minutes needed to perform this kind of clinical score exactly as proposed by the International Prophylaxis Study Group. But I would like to focus you on two items of the score, duration of swelling and swelling. And I think that are maybe the most important items that we are looking for. And I will explain later better what I would like to say to you today, what kind of information. Please, next. But when we are looking clinically to a patient, where we are assessing clinical a patient, are we sure that are we looking the right way our patient? Please, next. Because maybe sometimes we are in the wrong way, or maybe clinical assessment is not enough to detail exactly what we are looking for. Please, next. So we have to have in our hands some of our other cards to use in our playground, in our clinical assessment, in our outpatient clinic. Please, next. And the ultrasound, especially point of care ultrasound, is something really useful in order to help us in a limited time in our outpatient clinic, and is able to give us a lot of information about the joint status of our patient. Please, next. And the availability of a really helpful tool, easy tool as that score and other tools that we had in the last years is as a point of care ultrasound is something really useful in order to help us in our work. Please, next. And why ultrasound is really useful? Because in a simple way, we are able to detect and joint bleed and to understand if we are talking about joint bleed or something different. Please, next. Because sometimes during our assessment, could be doubtful. Is a subcutaneous bleeding, is a hematoma, or if we have a joint bleeding. And of course, ultrasound is able to help us in a really easy way. Please, next. And next, we will be able easily to understand where is located the bleeding, and we will be able to understand if it's a joint bleeding. Please, next. And of course, a lot of time we assessing our patient, we could have the doubt, we are looking for a joint bleed or it's a joint effusion related with osteoarthritis. And the hemophilia, ultrasound in hemophilic patients have been demonstrated to be able to make this decision, to make diagnosis if we are in face of a joint bleed on osteoarthritis. And this is really, really important question to have an answer in our field. Please, next. And we have a lot of words that are able to say us that we are able to detect a joint bleeding even with a little amount of blood in the joint. Please. And this is true as we already know in other pathologies we can do also in hemophilic arthropathy. Please, next. And it's quite, using ultrasound, you'll be able to have a motion, an active assessment, please. And you will be able to understand if you have a fluid in the joint, if you are a joint bleeding in the joint. Please, next. As you can see in this image, if you squeeze the joint, if you squeeze the knee, you will be able to look at the fluid in the joint and you can understand that we are talking exactly a joint bleeding in the joint. You will be change the progression of the joint involvement for your patient. Please, next. And you will be able to understand also the phases of bleeding in the joint. Please, next. Please. But of course, other question that we have to solve is we are talking about only joint bleeding or we are talking about synovitis, please. And if we are here today, maybe it's because we are talking about synovitis. Is still till today is one of the outcome measures of our treatment in hemophilia, please. And coming back from the beginning, in talking about swelling. Swelling, why is important? Because it's the item that we have to look at in order to detect as soon as possible the presence of synovitis in our patient's joint, please. But clinical assessment is not enough to detect synovitis, especially in ankle joint, especially in the pediatric population. And ultrasound, as point of care ultrasound, has been demonstrated to be able to detect chronic synovitis in patients with hemophilia, even where clinical assessment were not able to do that. Please, next. And it's not so hard to do that. And I can show you the kind of image that you can see with ultrasound. Please, next. You can see that there are different aspects of synovium in the first picture and blood clots bleeding in the joint in the second picture. You not need to be a radiologist, you don't need to be an expert orthopedic surgeon to understand that there is a difference between synovitis and bleeding in the joint. Please, next. So, of course, sometimes you can have a problem. If you have a patient with chronic synovitis and he has a bleed in this joint, you have to look about how the joint change during time. Please, next. And ultrasound is able to perform diagnosis of synovitis, and you will be able to treat your patient when you perform a diagnosis. Please, next. But also you can be able to detect cartilage damage. Please, next. And you know that a lot of, or even orthopedic surgeons that say that ultrasound is not able to detect cartilage damage, but you can show here, you can see the image of ultrasound and MRI, and please, next, you can be able to see how it's different between a normal joint and joint with the cartilage involvement. Please, next slide. You can see, please, next. You can see how it's different, how the regular, the smooth image of cartilage in the previous slide, how it's changed, how it's destroyed in this image, the cartilage profile, and it's a sign of cartilage and osteochondral image. So ultrasound could be useful also in order to detect joint damage where there is not a history of joint bleeding, also where there is not a history of chronic synovitis. Please, next. And next, I can show you that even few damage could be detectable by ultrasound. Please, next. But now we are talking about clinical assessment. We talk about ultrasound. Please, next. But we have to talk also about function. Please, next. Because it's not a question also only of structure or clinical changes, but it's also a clinical history, an history of function alteration, the history of hemophilic arthropathy. Please, next. And if, of course, sometimes function changes can happen even before structural changes. Please, next. And when we talk about functional assessment, of course, it could be hard to understand what is practical use in your clinical routine practice, what is possible to do in 20 minutes. Please, next. And because it's a question of cost, it's of course a question of time, and sometimes it's a question of space. Please, next. So some years ago, we started to use a force platform because we suppose that it could be practice, it could be useful, even in outpatient clinic. Even just in 51 seconds, you can start to have some information about function of your patient. Also because stand-up position is the first step of function. So even if with a force platform, you can be able to have information about function for your patient. And this is critical to think about function for your patient in order to be able to prevent the onset of joint damage in the person with hemophilia. Please, next. And we have demonstrated that this kind of information could be useful in order to prevent and to create a rehabilitation protocol for people with hemophilia, especially in children with hemophilia. Please, next. So, in conclusion, in 20 minutes, you can do a lot of things with the people with hemophilia. And the goal of our job, the goal of this 20 minutes is to do diagnosis, is to treat patient as soon as possible. In these 20 minutes, you have to get information in order to change the clinical history of your patient, to change the history of treatment of your patient. So please, next. I hope that I was able to give you some answer that's not possible to find on internet. And I gave the word to speak to Professor Nair after me. Thank you very much for your attention.
Thank you very much, Gianluca, and also thanks Glenn, Donna, and Julia for arranging this, and also the opportunity for for me to share not only about the laboratory diagnosis, but also on how to overcome some of the limitations that exist when you have limited resources settings. And I think I should thank WFH for providing me that knowledge by allowing me to volunteer for a lot of workshops that they conduct. Next slide, please. Have no disclosures. Next slide. So all of us know about this textbook version of how the blood clots, both by the intrinsic pathway and the extrinsic pathway. This was published in 2 important journals in 1964. We know that the intrinsic pathway is by contact activation of factor 12 which activates factor 11 to 11A, which activates 9 to 9A, which combines with factor 8 to activate factor 10. In the other side, you have the extrinsic pathway, which tissue factor liberated at the time of injury combines with factor 7, activates factor 10. And then, of course, you have the common pathway where the 10 activates prothrombin to thrombin with the help of factor 5. And then finally, the thrombin creating the fibrin clot. So these two pathways were introduced, extrinsic pathway by Robert McFarlane from Oxford, and the intrinsic pathway, which was called the waterfall hypothesis, by Davy and Oscar Ratnoff from Cleveland. Next slide, please. So the method by which we can identify whether there's a deficiency in this clotting mechanism is by doing a few tests. One is the APTT, which is the activated partial thromboplastin time. All of you are aware of this test because you're involved with managing patients with hemophilia. It's defined as a time taken by a recalcified citrated plasma. That is where you collect the blood by anticoagulant citrate. And then to get the plasma to clot, you have to recalcify it. To clot in the presence of the activators, the contact activators, as well as phospholipid, which is called the partial thromboplast. And this, of course, will reproduce the intrinsic pathway that was that's very classically shown. So you can see that these particular factors which are involved with hemophilia, that is factor 8 and factor 9, are very much in the intrinsic pathway. Next slide, please. Most of the reagents will give you a time between 27 to 37 seconds. That will be the reference or the normal range. But it can differ slightly up and down with different reagents. But the standard requires you to put the time that you obtain on the patient plasma with the reference range that you may have in your lab or an acceptable reference range that a manufacturer provides you. Some people like to use a ratio, that is patient time divided by the normal plasma time, and usually a ratio of more than 1.2, which is 6 seconds more than the normal plasma, will indicate that we have a patient who has got a prolonged or an abnormal activated partial thromboplastin time, which basically indicates the deficiency of the intrinsic pathway factors, factor 12, 11, 9, 10, 5, prothrombin, and fibrinogen. Next slide. In addition to the APTT, we have another test called the prothrombin time, which is basically reproducing the extrinsic pathway. The representative picture is slightly wrong. It is basically the time taken by recalcified citrated plasma to clot in the presence of the activator, which is tissue factor or tissue thromboplastin. The prothrombin time reagent is nothing but tissue thromboplastin. So tissue factor, of course, will combine with factor 7 and activate factor 10, which converts prothrombin to thrombin. And the end point is the fibrin clot formation, which is detected by the mechanisms or methods that the lab may use. Next slide, please. So now you can see very clearly that from the picture that the most critical test that you require for identifying a patient with a bleeding disorder who may have hemophilia will be the APTT, because APTT is where the heart of the APTT is the 8 and 9, which is absent in patients with hemophilia, and that will be abnormal. So it's a very good screening test for hemophilia. And next slide. So it can be APTT can be done from a basic methodology, which is a manual method, which is using a water bath, which is not very expensive. So here you can see a picture where you can see the patient's plasma that is kept in the water bath, because you must realize that most of the coagulation reactions are enzymatic reaction. They have to take place at 37 degrees centigrade. So this water bath is maintaining a temperature of 37 degrees centigrade. All the reagents that are to be used for the test, that's APTT reagents and calcium chloride for recalcification, is kept at 37 degrees centigrade for over 5 minutes, so that it comes to the same temperature. And then you add the activator. And once the activator is added, you take the tube into your hands and keep it mostly at 37 degrees centigrade and tilt the tube, and then you take it back into the water bath and tilt the tube again, till finally you'll come to a particular point where the liquid plasma, which is the liquid plasma, the liquid reagent, will start clogging and forming a coagulum, which stops the movement of the plasma, and it forms a solid clot, which will be slightly turbid in color. So you have two changes that happen: the turbidity of the plasma and the movement of the plasma stopping. So as we mentioned earlier, definition of APTT is the time taken by the citrated plasma, recalcified citrated plasma to clot in the presence of an activator. So now you can see the clot formation. Of course, many of the other centers may probably use a coagulometer, which also uses a similar method of either identifying turbidity or the lack of movement in trying to identify the endpoint, which is the clot formation. So if identifying the reagent, is so simple as this test that I showed you, and sometimes what happens is the affordability for the coagulometer, which automatically detects the clot, may not be there. But I would say that if a lab is able to reach at least a prothrombin time of 20 per month, they can easily afford the manufacturer to place an equipment so that the manufacturer can sell the reagent and overcome the cost of the reagent. So now what is the issue? Do we have difficulty in getting this test done either by manual method or even if you are able to get an instrument? Next slide. Yes, it is a challenge. And the primary challenge is mainly from its logistical constraints, availability of trained personnel, availability of reagents, trained personnel having good sample collection criteria, which may not be that easy. And the other common problem is less referrals from clinicians because the suspicion of bleeding disorder may not be there. And therefore, testing may not be that frequent. And suppose you have all these things, then you must have personnel who are motivated to develop the non-mandated lab procedure, like mandated lab procedure like HIV testing, hepatitis B testing, which are mandated in every place. But non-mandated tests like PT, APTT may require some motivation for trained personnel to do it. But among all these issues, the most critical is the lack of reagent, because either there is no supply of reagent or the manufacturer is not available there, and is also the supplier is not regularly supplying the reagent. Cost is, of course, a major factor there, and it gets worse because the reagents will have short shelf life and also a short window within which most of the tests or assays have to be. And then suppose something is you are able to retain it and able to store it, you need stringent conditions for sample as well as reagent storage. Next slide. So how do you overcome this? There are strategies. It is nothing is impossible. So there are strategies. Let's go by it in a clockwise manner. So how do you overcome this? Is make do with what is available. You maximize the supply and minimize the wastage. You can use simple storage solutions and develop in-house reagents which you can make in your own lab. So this can be done by sourcing simple material and instrumentation, and also getting simple storage solutions which has got continuous power. You can also use these reagents to increase the reliability and reduce the risk of failure of discontinuation of a test. Because once you have a failure of a test, the clinician referrals will decrease. But if you produce a very good test, that the clinician will be very happy because this is what the clinician was suspecting and it correlates with his clinical criteria. So therefore, if you use good methodology and with this particular methods that you have developed and using strict internal quality control, you'll start gaining the trust of the physician. And then you can see, so it's automatically that will lead to increased referral, more tests, more consumption of reagent, busy and increased burden of work will start going into automation, and that will start bringing in the big manufacturers or suppliers into the country. Next slide. So what are the screening tests that you can do in low resource environment? Of course, as I said, PT and APTT. Is there a issue with choice of good reagents? No, not an issue. Most of the manufacturers are able to send their reagents into any country through either directly or through distributors. But the biggest issue is frequency of testing. Some labs will be doing one PT or APTT per week or per month to more than some labs doing one per day, more than one per day. So that becomes a huge issue because the shelf life of reagents, for example, PT reagent, thromboplastin reagent, after reconstitution is usually 1 week, is what the manufacturers say. And most of these vials will not contain less than 3 microliters because 303 milliliters, which is 3000 microliters, which is basically necessary for maintaining the matrix of the reagent. If you're doing a manual method, you may consume a good amount of it, but if you're using a semi-automated instrument, you may consume only a very small amount. So there'll be a lot of leftover reagent that you can have in the lab if your frequency of testing is not very high. Next slide. So there is a strategy that we use. So now you have 2 vials in the fridge. You open your fridge. Now you have 1 vial which you have freshly reconstituted, which is supposed to be lasting only for a week. But what you do is take the reagent, and immediately after you take the reagent required for the test, you keep the reagent inside. I mean, you take some reagent and put back the vial immediately. Don't keep the vial outside for a long period of time. So you take whatever is required for the test, close the reagent bottle and keep it back in the fridge. Whatever reagent you require, you take it for the test to the water bath or your instrumentation. Next slide. And then after the test is over, whatever little bit remains behind, you can use in another vial, which is labeled as used PT reagent or used APTT reagent, and pour the reagent back into the that particular vial, which you can use probably within a week or 10 days after the reagent was reconstituted. While the reagent which is freshly reconstituted remains in the fridge till your next patient comes. You know, we have noticed that if you maintain this temperature control of the storage of the reagent which is reconstituted, at least for 1 month without any hesitation based on the studies done, you can use these reagents. But I have got people who have used this strategy for using PT reagents which was constituted a year back. That is almost 12 months back. Next slide. So what about hemophilia? We need APTT to be done. We need mixing studies, factor assays, inhibitor screen. Again, the issue is infrequent referrals. As far as APTT reagent, you can use the same strategy that I showed you with the fridge. But you must select reagents which are sensitive to factor deficiency or even for heparin monitoring, but not as much as sensitive for lupus anticoagulant. Next slide. Now coming to the most important test that you need in your lab, which is correction studies by mixing studies. This is one of the most important tests for any hospital that manages any type of bleeding, whether it is acquired bleeding or inherited bleeding. This test is probably the most important. It allows you to differentiate whether the patient who is bleeding has factor deficiency or an inhibitor which is causing the, or patient is on heparin which is causing the bleeding. So for this, you require normal pooled plasma, which you use to mix with the patient plasma, which may have either the factor deficiency with either 8 or factor 9. Next slide. So the rationale of mixing study is that if you mix normal plasma, you would have overcome the deficient factor, and on mixing, you will get normalization of the abnormal APTT. There are some ways now. Once you identify factor deficiency, you need to know whether it is factor 8 or factor 9. For that, you can have selective plasma if you have plasma in your lab. If you have a selective plasma which is deficient in factor 8, you can get it from a patient with hemophilia A. Or if it's deficient in factor 9, selectively deficient in factor 9, you can get it from a patient with hemophilia B. You can commercially obtain it. But this is like a place where you don't have either of this. It's like a chicken and egg story. So for that also, there is a solution. You can artificially create selective plasma by absorbing the vitamin K dependent factors with either barium or aluminum hydroxide. Or if you don't have those reagents, you can create what is known as age serum. Age serum is something that is available in any laboratory, any hospital, in anywhere in the world, because it's basically blood from a normal person which has been kept to clot, and after clotting, it has been kept in the room temperature for 48 to 72 hours. So if you go to the biochemistry lab, you will get an age serum. If you have, you go to the blood bank, you'll get an age serum. So with this particular thing, you can get age serum from anywhere. Next slide. So how do you use this adsorbed plasma age serum? So if you mix, suppose you have a patient here who has got an abnormal APTT and there is deficiency in factor 8, you mix it with adsorbed plasma. Factor 8 in adsorbed plasma will reconstitute the factor 8 in the patient, while age serum does not have factor VIII, so that mixture will not contain factor VIII. So when you do a repeat in APTT on that mixture, only the adsorbed plasma mixture will give you correction, while the VIII serum will not get correction. So if you have a patient and you don't have adsorbed plasma, you just have VIII serum. With that, you can able to identify what deficient factor it is. Next slide. So now with the humanitarian aid, there is plenty of factor concentrators available in most of the hemophilia treatment centers. You can use them as a reagent to identify whether the patient who's got a prolonged APTT has got factor deficiency or not. So, you can just take a drop of the factor deficient plasma, dilute it with water, saline or distilled water, and very small amount of that, if you add to the plasma, patient plasma, which gave the abnormal time, and repeat the APTT. Next slide. If you get the APTTs corrected, that means you have a patient with hemophilia A. If it doesn't get corrected, most likely it will be hemophilia B, which you can use the factor IX concentrator and repeat the same thing. There is a good chance that if you don't get correction with either, there's a small chance that this patient is likely to have a inhibitor. So you can identify factor VIII deficiency, factor IX deficiency, and also patient with inhibitor. Next slide. So factor assays are necessary once you get to the particular identification of factor. For that, you require important reagent, most important being the calibrator, which you can make at your own lab by pooling 20 normal people, and factor deficient plasma from generous donation from one of the patients who has got who is not on treatment and is able to donate the blood for extracting plasma. Next slide. Now, when you're making your own plasma, you would like to store it because for future when patients come, you would like to use these reagents. Now, ideal storage, they say, is minus 80 degrees centigrade or minus 20, but you can see the cost of these storage solutions are 10 to 15,000 USDs. And if it's lesser than that, it is 3 to 4,000 USD. But many of our trainees, when they go back, next slide, please. They use, I have told them, why can't you use refrigerators which are used by ice cream vendors? Keep it closed as much as possible. Only use it when you need the reagent. The cost is 250 USDs. The temperature can be between minus 18, not ideal. It will be lesser, but some of them can give you minus 22 if you don't open it that frequently. You can have continuous power by a standalone UPS. So this can actually allow you to use plasma in your lab for up to 3 months. And I have got people who have used my factor 7 deficient plasma even 6 months, and it performed very well. Next slide. So you can make your own controls in the lab, even normal controls from normal people and abnormal controls by patients who have been, who are on oral anticoagulation. You can use and pool them and make abnormal plasma. So it's good to have controls because once the controls are there, you can be confident about your test results. When you give the clinician clinician has a confidence in doing the particular test. Next slide. Of course, once the volume goes up, you can shift to commercial reagents because the lab will become busy. Inhibitor screening, I will skip this slide because there's lack of time. Next slide. So whatever numbers that you have, whether it is 1 test per month or whether it is 100 tests per day, please make sure that you should participate in a proficiency testing program like WFH IQUAS, which helps you develop confidence that the lab is giving out correct results to the clinician. And of course, if the clinician is able to get reliable results, he will frequently send the test and allow the test to happen. Next slide. So again, about motivation, doing non-mandated tests, why can't we shift some of the tests that was required for hemophilia as mandated tests into transfusion services, because these services manage hemorrhagic conditions like postpartum hemorrhage, viral hemorrhagic fever, trauma coagulopathy, because these tests like fibrinogen factor VIII and APTT are required for managing the coagulopathy. Next slide. Thank you very much, and I hand it over back to Glenn for question and answer sessions. Thank you.
All right, thank you very much, Sukesh. Appreciate that. And to all three of our speakers, thank you for your talks this morning. They've been innovative and interesting. We have time for just a couple of questions. I wanted to ask Cedric, I think the question here is, treatment for hemophilia has improved, hemophiliacs are living longer. Is treating in a hospital the desired trend? So I think this is a question about the use of home care therapy versus hospital-based care. Can you make a brief comment on that, Cedric?
Well, here I focus, on the clinical follow-up in hospitals, but it is clear that the proper management of hemophilia and other bleeding disease requires that patients be able to inject themselves at home. This is clear. So home treatment could be, intravenously or by skin injection with some new treatment. All the patients should be able to do that at home. And if these are children, that should be done with the support of the parents. It does not make sense in 2021 to ask every patient to go to the hospital every time they need a treatment. That's a nonsense.
Okay, thank you. I fully agree. Gianluigi, I've got a question here for you. It's a broad question about pseudotumors and really involves how to either prevent them or treat them. And so maybe you could just focus on ways to identify them early before they even become full-fledged pseudotumors and what to be looking for. Briefly, please.
Yes, of course, pseudotumor is a complication of treatment. So it's a question of a trauma or a bleeding undiagnosed and continue to bleeding and transform in pseudotumor is the reason why, unfortunately, pseudotumor is quite often complication in countries where with low incomes and low availability of treatment. And so in order to prevent, it's important to make diagnosis of trauma in order to treat how long is it necessary this kind of bleeding. And about treatment, I would like to say as surgeon that the treatment of pseudotumor is really quite complicated treatment. You need an experienced multidisciplinary team, and you have to know that maybe sometimes you need an expert radiologist, an expert rheumatologist, an expert orthopedic surgeon, and maybe sometimes a general surgeon if you have to treat and manage pelvic pseudotumor. So it's really important to do all your best before surgery to plan surgery and after to be able to perform the best surgery for your patient and follow him during times.
Okay, thank you, Gianluigi. And then a question for Sukesh. Sukesh, you gave a very nice series of examples on using homegrown reagents, reagents that you can obtain locally as for your quality control, for your factor VIII deficient plasma. And yet a number of laboratories are reluctant to do that. Can you perhaps in a brief way comment on how one can get more comfortable with the use of reagents that you can find in your hospital or among your patients?
Yes, the major restriction on making your own reagents is mainly because of the effort that goes into it. And to translate that effort into able to aliquot it so that you can use it for longer period of time so that you don't have to frequently make the reagent. So the biggest stumbling block is how do you store the aliquots, and there may be not facilities available to store the aliquot. The simplest solution I showed you is using those ice cream vendor freezers, but sometimes it may not work. There can be small liquid nitrogen canisters that you can, it's not very expensive, and you can fill it with liquid nitrogen based on when you have reagents inside in the frozen state. So it is basically the storage solutions that prevent people from making their own reagents. Once that is overcome, it is just a matter of time that they start making their own reagent, because most of them are working with hemophilia treatment centers and with the local chapters. I'm sure a lot of people will come and donate deficient, and people will come and get the normal pooled plasma also.
Okay, thank you, Sukesh. There's another question in the Q&A that perhaps you can answer directly in the Q&A. I'm going to turn it over. That, okay, yeah. So I'm going to turn it over.
I'll type the answer for that.
Okay, thank you. I'm going to turn it over to Marlene now for our next three speakers. Marlene?
Thank you, Glenn, and also Cedric, Gianluigi, and Sukesh. I'd like to introduce to you our next three speakers. First of all, Margaret Ozello. She's Associate Professor of Internal Medicine and Director of the Hematology Division from the Unicamp in Brazil. And she's also the Director of the WFH International Hemophilia Training Center from Hemocenter Unicamp. And Dr. Ozello is involved in several research projects, including gene therapy for hemophilia, risk factors for inhibitors, and ITI, and the management of MSK complications of hemophilia in inherited platelet disorders. After Margaret, we will have Radek Kaczmarek. He is a postdoctoral research associate at Gene and Cell Therapy Group in the Wells Center for Pediatric Research in the Indiana University School of Medicine in Indianapolis. And Radek, he chairs the Coagulation Product Safety Supply Access Committee of the World Federation of Hemophilia, and he is also a member of the European Hemophilia Consortium Steering Committee and a board member of the Polish Hemophilia Society. And our final speaker is John Pacey, a professor of hemostasis and thrombosis at the Barts and London School of Medicine and Dentistry at the Queen Mary University of London. And he has a clinical practice that spans both adults and children and covers all aspects of hemostasis and thrombosis. He is closely involved in the design and development of many trials, therapies in phase 1 to 4 programs. He has been part of the development of national policy guideline formulations for the hemostatic and thrombotic disorders and training initiatives such as residential academies and online education training. And with that, we will move on to our first speaker, which is Margaret. So the floor is yours, Margaret.
Thank you, Marlene. And first of all, I'd like to thank you, WFH, especially Glenn, Donna, and Julia for this opportunity to talk to you about the chromogenic assay, giving you the clinician's perspective how these assays can be useful. Next, please. So here are my disclosures. Next. Well, first of all, let's talk about why and when we needed to measure factor VIII or factor IX activity. Of course, for the diagnosis and to assess the severity of the disease, but also to monitor the factor VIII and factor IX therapy in prophylaxis and to have the pharmacokinetic parameters. Next, please.
Oh, Tori's back.
And what we also have is to measure factor VIII and factor IX as part of the Bethesda-Nagman assay to evaluate the presence of neutralizing antibodies or the inhibitors. What it means, we needed to measure the remaining factor VIII or factor IX in the samples, so we also needed to use some of the assays available. Next, please. And how to measure the factor VIII and factor IX activity. So as Dr. Sukesh already discussed with us, one of the most common way is to use the one-stage assay. That is APTT-based assay. It's very simple, very common use. We also have the two-stage assay that is also related to APTT-based, but what we are looking for is the thrombin generation. It's now common usually, and it was replaced by the chromogenic assay. That's what I will discuss with you. And here, what we are looking for is the activate factor 10 generation. Next, please. So very briefly, how the one stage works. As was already discussed with you by Dr. Tsukeshi, what we needed to do is to add 3 different elements to the patient's plasma. If we wanted to measure the factor VIII activity, we add the factor VIII deficient plasma with or without von Willebrand factor. Or if we are measuring factor IX, we needed to add a factor IX deficient plasma. We also needed to have a source of phospholipid and the activator of the contact pathway. Then the timer restarts with the addition of calcium until the clot is forming. And with that, we can use the optical or mechanical way to evaluate the formation of clot according to different equipments, or as what said, even visually when we are using a water bath. Next. So one thing that we needed to keep in mind is that we have several different reagents, several different types of activators, ellagic acid, silic, kaolin, also different sources of phospholipids, and even the calibrator that we are using when we are measuring factor VIII or factor IX can be different according to the parameters that is used. Next. So because of that, we also have some limitations related to the one-stage assay, especially a considerable inter- and intra-laboratory variation due to different instruments, different reagents, and also we needed to keep in mind that sometimes we can have the interference of the presence of antiphospholipid antibodies as lupus anticoagulant. Next. So the chromogenic assay, and here I will briefly talk with you the chromogenic factor VIII assay, has a different approach. So the plasma, the patient's plasma, if we are measuring the factor VIII, we first needed to add a prothrombin or thrombin to activate the factor VIII that is in this sample. Once we have the activate factor VIII, we also will have a mixture of activate factor IX, phospholipid, calcium, and this mixture is able to activate the factor X. Now we have activate factor X, and at the second step of this method, we add a chromogenic substrate that will recognize activate factor X, changing the color. And that's the way that we can measure and evaluate the factor VIII activity. Next, please. So we already have several different commercially available chromogenic factor VIII assays. And one thing that I wanted to show to you is that we needed to be aware that some of these kits has bovine or human proteins. And this can be important, particularly when we have emicizumab in our sample. And I will talk about this later. Next, please. And in terms of the chromogenic factor IX assay, is a little bit different. Of course, if the plasma that we want to measure is the factor IX, first we needed to activate factor 11 to be able to activate this factor IX. And then we have a mixture of factor VIII, and we use thrombin or prothrombin as it was first discussed, to activate the factor VIII. Then the phospholipid calcium will be able to activate factor X. And again, it's the same way. We have a second step with a chromogenic substrate that recognize activate factor X, and this change the colors. Next. So we also have some commercially available kits for chromogenic factor IX assay. But I must say that this is not as common as for factor VIII. Even I can tell you that in Brazil, we don't have any of these kits that is already registered here. So they are not commonly available as factor VIII chromogenic assay. Next, please. Okay, so let's talk in the clinical point of view. So first, how to, when we wanted to monitor the factor VIII treatment, how we can see and interpret the factor VIII activity. Well, when we are using standard half-life factor 80 concentrates, we need to know that many times this can be different according not only the reagents that is available, but also the type of the concentrate, if it's full length or B-domain deleted product. Usually what we are seeing is that the chromogenic assay is better, has better laboratory agreement in the field studies. And related to the extended half-life factor 80 concentrates, what we are seeing here is that the examples of 3 different products that is now routinely used. And as we can see, the chromogenic assay can be used for all these products. But in terms of the one stage, it depends the reagent that you are using can have a different results. Next, please. So for the factor 9 activity, as we can see for plasma-derived factor 9 products, is quite, there is agreement between the results of the one stage and the chromogenic assay. But when we are measuring the recombinant factor 9 can be a little bit different, and the chromogenic factor 9 activity can be 70% lower, 70% of what we are seeing for the one stage results. And this, of course, will depend on the reagents that we are using in the one stage assay. Next, please. And related to the extended half-life factor 9 concentrates, again, here we have 3 different products. And as you can see, the chromogenic factor 9 assay can be used for all these products, but is the same as factor 8. Here, it depends for the one stage, the reagent that you are using, if you will have a reliable result or not. Next, please. And related to the endogenous factor 8 or factor 9, well, sometimes we can see some discrepancies according to the method that is using. So, for example, for non-severe hemophilia A, it depends for some particular factor 8 mutations. We can have higher results when we are using one stage. And as an example of this, some mutations that happens in A1, A2, or A3 domain can have different discrepancy between these 2 methods. In the other hand, there are other situations where the chromogenic assay give us higher results than one stage, and usually is related to factor 8 mutations that happen in the von Willebrand factor or activate factor 9 binding sites, or mutations that happen in thrombin cleavage sites. So the recommendation here is actually to consider the breeding phenotype for the severity assessment for your patient, and also the other members of the family. Also, for non-severe hemophilia A, most of the recommendation actually tell us to use both one stage and chromogenic assay at least once to determine the severity assessment. But for hemophilia B, we still not have enough information related to that. Next, please. Okay, and more recently, we also needed to know some difference that we are seeing related to the products of hemophilia gene therapy. So for hemophilia A gene therapy, most of the trials are using B-domain deleted factor 8 transgene or factor 8 SQ. And what we are seeing, and this seems to be quite repeated times, that the chromogenic factor 8 assay is 60% less than the one stage. And for hemophilia B gene therapy, the most recently trials are using the factor 9 Padua transgene, a mutation that increases the specific activity. And again, we also are seeing that the chromogenic factor 9 activity is 60% less than one stage. And as an example, we can see in this graph, where each colors represent one sample measured using different one-stage reagents and also the chromogenic assay. So as we can see, except for one sample, the chromogenic result is lower than the ones using different reagents for the one stage. Next, please. And finally, what about to measure factor VIII assay in the presence of emicizumab? Well, we know that emicizumab interferes with the clothing-based assays, and such as APTT and one stage. So the recommendation is for factor VIII activity measurement, and to quantify factor VIII inhibitor, we must use, in the presence of emicizumab, we must use chromogenic assay containing only bovine proteins. But if we wanted to evaluate the expected emicizumab levels, it's also possible to use a modified one-stage assay using emicizumab-specific calibrator. Next, please. So in summary, what I may say is that the chromogenic assay, although is more expensive, and just to give you an idea, here in our lab, the chromogenic assay costs twice as what we are paying for the one-stage assay. But we hope this became more available. And it's quite clear that the chromogenic assay can solve some of the limitations related to the one stage. In terms of to monitor factor VIII and factor IX, it seems that the chromogenic assay is more reliable than the one stage. But the main message here is that clinicians, please, you must talk to the laboratories. Tell them which product are you using in your patient that you wanted to monitor. And the laboratories must talk to the clinicians about what is the potential bias according to the reagents and the methodology that they are using that can be changed or interfere in their results. So what I can say is that the communication between clinicians and the laboratory staff is really a key issue here. Next, please. So with that, I would like to thank your attention, and I will be happy to take your questions later. Thank you very much.
Hello, my name's Radek Kazmarek. I am the chair of the Coagulation Product Safety, Supply and Access Committee of the World Federation of Hemophilia. And in this talk, I am going to give you an overview of how treatment products for people with bleeding disorders are made. Next, please. We will take a little trip down memory lane to help you understand why the current landscape of products is what it is today and why it matters. The earliest successful attempts to treat symptoms of hemophilia were made in the mid-19th century by Samuel Lane. The treatment was whole blood, and it continued to be the only known remotely effective treatment until 1920s, when plasma was first used, but it wasn't widely used until 1950s, and its efficacy was still very limited. Next, please. Subsequent improvements happened thanks to two major technological breakthroughs. The first one was successful isolation of albumin by cold ethanol precipitation in 1940s by Edwin Kahn, which saved the lives of many wounded soldiers at risk of hypovolemic shock during the World War II. That was the proof of concept that you could fractionate plasma and isolate therapeutic proteins from it on a large scale. Next, please. The next major milestone was the discovery that a cold precipitate that forms following slow thawing of frozen plasma contains high factor VIII activity. This cryoprecipitate could be easily separated from the rest of plasma and infused from a closed bag system. And it was a big leap in terms of being able to make it locally and infuse relatively high doses of factor VIII in a much smaller volume than previously, without overloading the patients with fluids. It is still being used today in the developing world for treatment of hemophilia, von Willebrand disease, fibrinogen, or factor XIII deficiency, and it fills a gap between patients' needs and affordability of better products. Today, it is by far a suboptimal product in terms of safety and efficacy. But at the time in 1960s, it was revolutionary, not only because it was an effective treatment, but also because cryoprecipitation was able to be integrated into the plasma fractionation workflow, spurred by Kahn. Next, please. So this, together with a number of chromatographic protein purification techniques which came along, allowed for efficient isolation of multiple plasma proteins, which could be freeze-dried, stored in a fridge, and used at home. These two seminal processes, cryoprecipitation and cold ethanol fractionation, are still used in modern plasma fractionation. Next, please. Refinements in the chromatographic purification techniques produced an array of clotting factor concentrates whose purity increased over time from less than 1% of total protein to over 99% purity by the end of 1980s in the case of factor 8 and factor 9 concentrates. The other clotting factors mostly lagged behind on that front, and some are still not commercially available. For example, plasma-derived factor 10 was commercialized just a few years ago, and plasma-derived factor 5 concentrate has been developed only recently and is still in clinical trials. Next, please. So here is what the fractionation workflow looks like today. Plasma from as many as 120,000 individuals may be pulled together in the process. First, plasma undergoes cryoprecipitation, and the cryoprecipitate is separated from what is now called cryopoor plasma. Both then undergo several rounds of ion exchange, size exclusion, and affinity chromatography, chemical precipitation, and viral reduction, optimized for specific proteins targeted in individual branches. Viral reduction steps have been an integral part of the process since the 1980s, and their importance cannot be overstated. Pulling plasma from as many as over 100,000 donors risks contaminating a whole batch of product, even if just one of those donors carries a blood-borne infectious agent. Next, please. Prior to the introduction of viral reduction measures, tens of thousands of people with bleeding disorders were infected with human immunodeficiency virus, or HIV, and hepatitis B and C viruses through their treatment products. A crackdown on the industry that followed those events produced multiple overlapping safeguards against the risks of transmitting pathogens. Next, please. Since the end of 1980s, no documented transmission of HIV or hepatitis B or hepatitis C viruses by products subjected to dedicated viral inactivation treatments such as solvent detergent treatment and dry heat treatment has been recorded. Use of two distinct dedicated viral reduction treatments targeting known enveloped and non-enveloped viruses is currently the gold standard. So this, together with the rigid regulatory framework, has worked extremely well so far and in preventing infections, and also proved to be effective against new viruses that emerged more recently, such as West Nile virus. However, uncertainty will always remain about emerging unknown infectious agents. Next, please. So just when the HIV disaster was unfolding in the beginning of 1980s, efforts were well afoot to solve the structures of factor 8 and factor 9 and clone the genes encoding them. This was particularly tricky for factor 8 due to its size, complex processing, and association with von Willebrand factor. And actually many at the time believe that factor 8 and von Willebrand factor actually made up one molecule before being further processed. But eventually two teams, one from Genentech in collaboration with Royal Free Hospital in London, and the other from Genetics Institute in Boston in collaboration with the Mayo Clinic, managed to clone the factor 8 gene and produce the protein in Chinese hamster ovary cells and baby hamster kidney cells, respectively. This raised the prospect of manufacturing safer treatment products, and indeed both constructs and expression systems made it into the clinic and were commercialized. Next, please. The first recombinant factor 8 was licensed in 1992. Recombinant factor 9 followed a few years later in 1997. Today, there is a range of recombinant factor concentrates available, almost all of them expressed in the two cell lines initially used, the Chinese hamster ovary cells and the baby hamster kidney cells, and more recently also in a human embryonic kidney cell line. The only exception is recombinant factor 13, which is manufactured in yeast species. The first recombinant factor 7, activated recombinant factor 7 concentrate is manufactured using baby hamster kidney cell line. And until not long ago, it had been the only available recombinant factor 7A for almost 25 years. But recently, another product has been licensed, and that one, interestingly, is produced by transgenic rabbits and purified from their milk. Recently, since not long ago, also a recombinant von factor is available, which is a significant progress over over previously available products, since very pure plasma-derived von factor concentrates have not been able to be obtained before. Next, please. In general, the choice of workhorse cell line for manufacture is limited due to complex post-translational processing of coagulation factors. Simple small proteins like insulin can be efficiently made in bacteria such as Escherichia coli, but large complex proteins need mammalian cell lines. Whether it matters if you do it in any mammalian cell line or a human cell line, we don't know yet. There were expectations that human cell line derived factors could be less likely to elicit inhibitor formation, but so far there is no evidence for that. Next, please. Several extended half-life products have been approved since 2014, and more are under development. They persist longer in the circulation as a result of chemical modifications such as pegylation, meaning a conjugation with a polyethylene glycol molecule, or tweaks to the genetic constructs encoding those factors, such as fusion with the Fc fragment of the immunoglobulin G or albumin. This has resulted in a modest prolongation of factor 8 half-life, but a substantial increase in the half-life of factor 9. New fusion constructs that promise to break the half-life extension limit imposed by von factor on factor 8 are in clinical trials. And all extended half-life recombinant products are made in Chinese hamster ovary cells or human embryonic kidney cells. Next, please. 4 years ago, the first and so far the only non-factor replacement product for severe hemophilia was licensed. It's a bispecific humanized monoclonal antibody that mimics activated factor 8, and so far that it binds activated factor 9 and factor 10, bringing them close together, and thus allowing for activation of factor 10 in the absence of factor 8. Next, please. Emicizumab was developed via recombination of a huge library of mouse and rat anti-factor 9A and anti-factor 10 antibodies, and it is being made in Chinese hamster ovary cells. Next, please. There is a range of other non-factor agents in clinical trials, including 3 other monoclonal antibodies. These are not mimics, but instead they target one of the physiological inhibitors of coagulation called tissue factor pathway inhibitor in an attempt to rebalance hemostasis when one of the coagulation factors is missing. These are humanized mouse or fully human IgG1 or IgG4 class antibodies made in Chinese hamster ovary cells. Next, please. Another rebalancing agent under investigation is a fully synthetic small interfering RNA. The RNA backbone has been chemically modified to increase stability because otherwise RNAs are extremely prone to degradation, and these modifications also prevent the recognition of the molecule by innate immune receptors such as toll-like receptors. The RNA moiety is conjugated also to a sugar called N-acetylgalactosamine, which makes the molecule able to be taken up by hepatocytes via a specific receptor, where it knocks down the antithrombin transcript. Next, please. And finally, there are multiple clinical trials of gene therapy for hemophilia. All phase 3 trials use adeno-associated viral vectors to deliver a gene encoding functional clotting factor to the liver. They are made in 2 very different manufacturing platforms. So one is the human embryonic kidney cell line, which I mentioned earlier. And the other one is ovarian cells of Spodoptera frugiperda, which is a lepidopteran insect. So far, neither platform has shown a dramatic advantage over the other in any way. Proponents of each swear by them. Having said that, they are very different, and it remains to be seen whether those differences ultimately matter for the patients in any way. Thank you for your attention. And I'll now hand over to Professor John Passy.
Okay, thank you very much, Radek. So I'm going to talk about rebalancing agents and the clinical data that we have to date. So could I go on to the next slide, please? Now, as you've heard just from Radek, there are a number of emerging agents for haemophilia treatment, extended half-life therapies, treatments that mimic clotting factors such as the bispecific antibodies that he's mentioned, and also treatments that suppress crop regulators. These are the key things in the rebalancing portfolio, and I'm going to talk about those. And of course, Radek's also mentioned gene therapy. So if we're on the next slide, if we could move to the next slide, please. I'm going to talk about rebalancing, and there are a few key concepts we need to bear in mind when we think about rebalancing therapies. The first is that they're almost entirely based on the concept that haemophilia is a disorder of thrombin generation. That is, you can't generate enough. That natural anticoagulants are the major regulators of hemostasis, and therefore, by opposing or suppressing these natural anticoagulants, we will rebalance hemostasis to allow clotting to proceed in the absence of factor 8 or factor 9. Importantly, all these treatments I'm going to talk about can be administered subcutaneously. Next slide, please. So the first slide here just really shows to you that indeed haemophilia is a disease of thrombin generation failure. We can see the control column with the peak curve, but then as we reduce factor 8 levels, we can see that the curves flatten out as less thrombin is generated, both in terms of amount, time, and total. Next slide, please. So let's think about it in terms of concepts. Here is our normal hemostatic balance, green representing procoagulant proteins, the browny color representing anticoagulant proteins. On the next slide, if we go on to that, we will see what happens in haemophilia. The simple idea is that we don't have enough procoagulant proteins, and so our anticoagulant proteins outweigh them. If we add back procoagulant proteins, then we get back to a hemostatic balance. On the next slide, we can think about the alternative approach to this. We can take away anticoagulant proteins so that we rebalance coagulation. And here we see that we've got less of both, but they actually balance each other out. So moving on to the next slide, we can see here an representation of coagulation as will occur in vivo. Now in haemophilia, clearly we lack factor 8 or factor 9, and so the whole of this central process disappears. And on the next slide, we will see what we're essentially left with in severe haemophilia A and B, at the extrinsic pathway. So this is where we've got to target our approaches to rebalance coagulation. And on the next slide, we will see what our targets are. Tissue factor pathway inhibitor, antithrombin as the key natural anticoagulant, and activated protein C. So moving on to the next slide, we'll start to talk about anti-TFPIs, which Radek touched on. So this shows 3 different cartoons on the left, essentially showing how this works. TFPI comes in to inhibit the 7A tissue factor 10A complex. And in panel B, you can see how it binds to this. By binding, it prevents further 10A being released. In panel C, we can see how if we had a monoclonal antibody to tissue factor pathway inhibitor, we could stop it binding to the ternary complex, and so we would release more factor 10A, so rebalancing coagulation. One thing that is important to bear in mind is that these antibodies you would think would last for ages because they have a long 21-day half-life or so. But in actual fact, every time they bind to TFPI, they are used up. This is called target-mediated drug disposition. As a result, we need to give these anti-TFPIs, albeit subcutaneously, but relatively frequently, daily for some, bi-weekly for others trials, and weekly in other programs. So on the next slide, I'm going to show you some of the clinical data from one of these programs using consuzumab, using the phase 2 data. Here we have 3 different panels. On the left, inhibitor data, patients. In the middle panel, haemophilia patients without inhibitors. And in the right-hand panel, patients with inhibitors in both haemophilia A and haemophilia B. In the left-hand panel, we can see how consuzumab compares against 7A treatment, and clearly it appears to be better in terms of reducing annualized bleeding rates. In the non-inhibitor population, we don't have a comparator because this is a phase 2, but we can see that the overall treated bleed rate is for an ABR is about 7, and for treated joint bleeds is about 5. And similarly, we can see across the board that we reduce bleeding rates compared to what we might expect on demand for haemophilia A and B with and without inhibitors using this, but it's not at super low levels of 0. We can still actually detect some bleeding. On the next slide, we can see 2 important features of these types of rebalancing treatments. The first, on the left-hand panel, is that it shows that you can increase thrombin generation with these approaches, which, if you remember, is key to the original concept. It secondly also shows that once you actually start treatment, that thrombin generation remains relatively consistent. The right-hand panel shows that when we use these treatments, we do increase, though, the D-dimer that we can measure in patients. So we can see the limits of quantitation and the upper limit of what we would regard as normal, and we can see how consuzumab does lead to an increase in the level of D-dimer. We'll come back to this later, as this may be relevant to some of the issues that have been seen with rebalancing therapies. Moving on to the next slide, I'm going to talk about antithrombin suppression as an alternative approach. As I mentioned, antithrombin is a key natural anticoagulant, inactivating 10A and thrombin, and so attenuating thrombin generation. What we know from other medicine is that antithrombin deficiency is associated with an increased thrombin generation, and that patients who co-inherit severe haemophilia and antithrombin deficiency have a much milder bleeding phenotype, reduced factor requirements, and fewer complications. That said, these co-inheritances in patients are really quite unusual and quite rare. On the next slide, what we're going to talk about is RNA interference and the technology that is used to suppress antithrombin to achieve and rebalance. This is a natural process, RNA interference, where foreign nucleic acid materials are broken down in cells and then attached to the RISC complex, RNA inhibition silencing complex, which bind complementary RNA so as to lead to RNA degradation of foreign material in cells. This is a natural process that is there to get rid of foreign nucleic acid materials. On the next slide, you can see how RNAi technology essentially hijacks this to enable gene silencing. We produce a synthetic small RNA molecule targeting a gene of our choice, which then goes into the cells and binds to the RISC complex so as to pull out the RNA of that specific protein, effectively leading to targeted gene silencing. This is what has been used to develop RNA silencing for antithrombin, which we'll see on the next slide, with a drug called fitusiran. So fitusiran is a small molecule, 23 nucleotides, targeting antithrombin, attached to GalNAc moiety, as Radek mentioned, so that it targets the liver. This can be given monthly, and interestingly, the dosing studies early on showed that you had a flat dose response curve at higher levels, so you could in fact use a fixed dose. On the next slide, we'll see some of the clinical data from this. This shows, again, much like concizumab and other treatments, that once you start using these treatments, you can get a flat response. Here we see antithrombin reduced, and we see that it is consistently reduced with a very tight distribution. In fitusiran, we see some variable D-dimer responses, but not that notable. The next slide will show that we can also see an increase in thrombin generation. So in red on the left-hand panel, normal donors. In the blue colors, patients with lower levels of antithrombin, and you can see they cross over. And on the right-hand panel, you can see as the antithrombin level lowers further, we see it overlapping with the normal human volunteer patient population. On the next slide, we can see how we get reduction in bleeding as we would expect. This is the open label phase 2 study for fitusiran, and I think you can clearly see that pre-study and during the observation in the program, we see reduced bleeding. So both these approaches appear to work. The next slide shows an alternative approach where we inhibit activated protein C. This has been done through modifying a specific mutant alpha-1 antitrypsin, which will bind activated protein C specifically. It again has a very long half-life, shown on the right-hand panel. If we move on to the next slide, we can see the very early preliminary data that has been presented at the recent EHAD meeting, a bleeding pattern after a single dose of Serpin-PC. The clear columns represent before treatment, the dose, the central line, and the yellow after treatment. And you can see there's a 55% reduction of bleeding. No elevations of D-dimers have been seen. Now, clearly, this is a single dose and very early studies. Moving on, though, what we have seen with these treatments is some concerns about safety and thrombosis risk, and mitigation strategies have had to be developed. The next slide will show us the data from one of these anti-TFPI programs where 3 severe significant thrombotic events occurred, none of them in association with replacement therapy, and all at levels of exposure to anti-TFPI which would be below those that one would normally expect for efficacy. As a result of these thrombotic events, this program was terminated. Moving on to the next slide, we will see the data from concizumab, where again there have been 3 thrombotic events: an acute myocardial infarction, a renal infarction, and venous thromboembolism, all of which were associated with additional factor replacement therapies when patients were being treated with consuzumab. There were mitigating factors in that others had thrombotic risks, they had been treated, and all had really high levels of consuzumab. The program has gone forward with using lower doses of consuzumab and consuzumab exposure level being used for dose adjustment so that the level can be kept at an appropriate, safer level. Finally, on the next slide, we will see the thrombotic events that have occurred with fitusiran. These are 5 in number. The first one was a cerebral venous sinus thrombosis, which was associated with additional factor use. Treatment regimes were then reduced with fitusiran to limit the amount of thrombin generation that occurred. However, other thrombosis events have occurred, particularly arterial events, and this appears to be associated with the particular level of antithrombin that is in the patients. If your level is less than 10%, you have a notably increased risk of vascular thrombosis compared to if your level is greater than 20%. So moving on to the next slide, we'll see the dose mitigation for this program, which has been again to reduce the dose of fitusiran rather than 80 milligrams every month, initially to 80 milligrams every other month, and then dose adjustment based on antithrombin levels thereafter to increase and achieve the levels that are desired. So in conclusion, on the last slide, we can see that the rebalancing therapies are a very new therapeutic approach to both haemophilia and also potentially other rare bleeding disorders. They're differentiated because they all require infrequent subcutaneous dosing that could be very simple to use and can address haemophilia A and B, all patient groups, including inhibitors. In global public health terms, this provided a huge opportunity because it's really simple. But the problem is that we see thrombosis. Risk mitigation is possible. We can use lower doses, but then with that, we'll use loss of simplicity of dosing and monitoring because we now have to adjust the dose and we have to monitor the treatment. Finally, we need to get some efficacy data on the new dosing protocols because these are clearly quite different from those that we've used in the early trials. So at that point, I'm going to hand back to the centre and thank you for listening to me. Thank you.
Thank you all. This is looking all very promising. And even for me, it was quite understandable. So thank you all for that. Margaret, what a good comment you made about the communication between the clinicians and the laboratory. It is so important that they, at the lab, they know what product a patient is using, and you made that very clear. I don't see any questions yet from the audience. I would really like to encourage people to ask any questions if there are. I have got a question to Radek. You were talking about the cryoparticipate in the developing countries. Is there now more difficulties in making those cryoparticipate? Now we have this COVID pandemic, that there are more patients hospitalized and that there might be any more blood transfusions. So we might have a lack of donors for making those cryoparticipates.
Thank you. Good question. Continued blood and plasma donation has been a challenge throughout the pandemic. So I expect that it has also impacted the ability to locally manufacture cryoprecipitate. But to what extent this has occurred, I'm not really sure. I think this is something to look at.
Arlene, can I mention that Glenn sent me a question in the chat? So,
yeah, I saw it.
Okay. The question is, rebalancing therapies could be important globally for managing haemophilia. How can we ensure safety? Well, I think this is an absolutely critical question. The rebalancing therapies offer a really simple approach, subcutaneous, infrequent, doesn't matter about the diagnosis to some degree, so that that makes things just a lot simpler. It's one treatment fits all, and they have a lot of potential opportunity. They can often be room temperature stable, pre-fill syringes, and so on and so forth. But the question is, how do we ensure the safety here? Because they do come with risks. And that is absolutely the issue. I haven't got a complete, well, I haven't got an answer for that at the moment, but it's really important, because I think that the opportunities that they offer are huge if we can ensure safety. So that's why I was saying, if we can have these risk mitigation strategies and they can deliver efficacy, and those lower doses come with safety, then that's going to be really valuable for managing haemophilia across a much broader population. But I think we've had to take a step back here, because we can't use those dosing regimes that we've used before, which we've got really nice evidence that they do work. We're a little bit taken 2 steps back here and got to start again, I think. But what we don't want is to, or we have to consider, is the trade between the thrombosis risk versus access. And these are really complicated issues that we need to think about as a treatment community.
Thank you, John. And questions are coming in now related to what you just said. There are 2 questions. The first one is, what is the half-life of concizumab and fitusiran? And the other one is, why not decrease the dose instead of increasing the time between the doses?
Okay, so fitusiran you can give once a month. Concizumab is given daily. Though it's a monoclonal antibody, which will have 21 to 28 day half-life, because of this thing called target-mediated drug distribution, you have to give it frequently, because every time the drug is active, it's used up, it's taken out of the circulation. That's why it needs to be dosed more frequently. So anti-TFPIs have to be dosed more frequently than you might originally think. So the dosing has stepped back, and the frequency, it's a combination of both to achieve the levels that we think are going to be safe. So it's not just about decreasing the frequency, it's about having to do both to ensure that on a population basis, the majority of patients will sit where you want them to in terms of levels of concizumab and fitusiran in relation to antithrombin suppression. So it's a combination of both. It's not simply one or the other, I'm afraid.
Yeah, and having said that, you already answered another question of how long is the duration of the treatment within these drugs. Yeah.
Yeah. So just to say one thing, that obviously with concizumab, it wears out much more rapidly. With fitusiran, though, we give it every month. Once you stop giving it, once you reach a steady state, it can take 6 months to wear out.
Yeah. There is another question. Is there sufficient evidence on the effect that COVID-infected patients who have hemophilia A or B on treatment and outcome? Does anybody has a question, an answer to that question?
Well, I could answer that, but I've been doing all the talking. So I don't think we feel that COVID infection is a particular, well, it's not a risk for haemophilia, and it's not necessarily a risk for management of COVID. Mechanisms and pathology of the illnesses are very separate and different. Arguably, but I'm not sure I'd really want to go out too far on this. You could say if you've got haemophilia, you might have a lower risk of the thrombotic associated complications if you're on replacement therapy, but the numbers are too small to actually really say that. But what we can say is that haemophilia is not a risk factor for getting it. It's not a risk factor that modulates COVID to make it worse for you as an individual, because most of the primary part of the illness is obviously pulmonary.
Okay, thank you. There is another question. Maybe I can hand it over to Margaret. What would be the option in cases without chromogenic assays, like a recommendation in some hemostatic agents, and how the laboratories can support the physician?
Okay, thank you for the question. I think it's very important. Well, as I said, the communication between the lab and the clinicians, and this is also related to what is the need for the clinicians and related to new products that has been used and all the things. I think we need more field studies to guarantee that the one-stage assay, that is the most common alternative for the chromogenic assay, can give us some answers about which will be the best option in terms of the reagents and the methodology that is used. But saying that, I will say that the chromogenic assay, there is a chance to become more available and cost effective. For example, I know that now in Brazil, as I said, it's twice the price as the one stage. In the past, it was more expensive, as in Argentina can be 5 times more. So, but I also think that the community who is really interested to use more the chromogenic assay is the community here. So probably with education, to have more expertise related to that, I think the chromogenic assay can be more available. That's my opinion.
Thank you. I've got another question for you. What is your opinion about the damage that the lack of availability of the chromogenic method in the lab can bring to the treatment of the patients?
Well, I think it's very important to understand the bias of the results that what we are receiving. Once we know that, we also know if we can rely on that result or not. For example, of course, because of the time, I didn't have time to discuss another issue. But for inhibitor measurement, we are seeing that for very low titer of the inhibitor, if we use the chromogenic assay, we can have results that is negative compared to when we measure the factor 8, the remaining factor 8 with the one stage. And this can make a huge difference, especially when it turns to do, for example, to evaluate ITI success and all the things. So I think the good communication between the lab and the clinicians can also help to see and to understand if I can rely in that result or not.
Okay, thank you. And then there is one question in French. As I speak French, I can pose it to Cedric, and you can maybe answer it in English. J'aimerais savoir si c'est grave pour un hémophile d'avoir un hématome sur la verge.
They answer in French.
Yeah, maybe, but also translate it in English, please.
Well, you know, and any kind of bleed should be avoided. So yes, you know, that could be, you know, problematic. So as any other kind of bleed, you know, that would request, you know, this is not purely a superficial bleed, so that could have some consequences. So I would suggest to treat that bleed, yes.
Okay, thank you. And maybe for Radek, what should be the priority treatment in low-income developing country among FFP pooled CFC standard recombinant HLs by specific like emicizumab for hemophilia treatment?
I think that in any country, no matter the income level, the priority should be the safest and the most efficacious treatment possible. And this, obviously, the choice will be limited depending on the economic status of the country, but there is still room for advocacy locally by the clinicians and patient organizations to to make sure that what they receive is the best, the safest product possible. There is not much room for that as far as the very early generation products like fresh frozen plasma and cryoprecipitate, although there have been available methods in the last few years to virally inactivate cryoprecipitate as well. But there is a choice, large choice of products among plasma-derived concentrates. They vary in methods of manufacture. They vary in the number and quality of methods of viral reduction applied during the manufacturing process. And I think anybody making decisions, having any impact on the decisions being made on this, and definitely patients and clinicians should be at the table when decisions like that are made. They should be well aware of those differences, very well versed and educated in how these products are made and how to differentiate them in the decision-making process.
Thank you. I've got another question. Margaret, how can we advocate globally to encourage more use of chromogenic assay?
Yeah, well,
is there an initiative where we can mount on?
I think the education is actually very important because, of course, we needed to have experts to perform the methodology. But as I said, I think these communities, the ones who really want is to have the access to this kind of assay. So maybe if we have a chance to use more and to encourage and see the possibilities, if we increase the demand for this reagents, so maybe this became more available in terms of the cost, and especially because now we have more modified products. And as we can see, sometimes, you know, the reagents that we are using in the one stage, that is also cost, because there is a cost there, because sometimes we needed to use, for example, 3 dilutions and to repeat that, and the result is not really what we are expecting. So we needed to learn more, and especially for the ones who already are using the chromogenic assay, I think we needed to share our results and our experience to actually increase the possibility to others to also use.
Yeah, thank you. That's really important. I've got another option or a question. What do we think of the impact of the introduction of all new therapies? What will the effect will be on the factor product availability for the rest of the world? And what will be the access to the new products? Well, the last part we already discussed a little bit, but what will be the effect on the production of the factor 8 and the factor 9s? Products.
Was that, sorry, that question was to me, right? I missed part of.
Well, what the impact of all those new products will be on producing the usual clotting factors and the availability for that then in the developing countries.
Right. Well, I think we can foresee several scenarios, and where we may well be wrong. Initially, when recombinant factors were being commercialized, there was an expectation that they would basically replace plasma-derived factor concentrates in the foreseeable future because of the relative ease of production, amenability to scale up, and to make them at a lower cost, basically, than plasma-derived factors. But they remained at a premium price to this day, and that replacement has never really happened. And what we see now, as we have new products coming on, new generations, the first non-factor product now being on the market, we see the effect on recombinant factor prices. And this also trickles down on the plasma-derived factors. What we see in some countries at, let's say, middle income, between those low income and high income countries, they seem to be getting stuck with plasma-derived factors basically at prices that are at so low levels that have been unprecedented before. So I think each of these generations will continue, including those old generations, will continue to play some role. Perhaps for plasma-derived factors, we'll see, perhaps they will replace in many countries the role that cryoprecipitate has played so far, meaning filling that gap between affordability and patients' needs. And hopefully, in general, that will translate to a better access to safe treatments.
Okay, thank you. Thank you all for attending. I'd like to hand over to Glenn. Oh, I see Glenn has already left. So then I will close off this first session of what we have planned this year, 4 sessions. I'd like to thank all the speakers and of course the WFH for supporting us in this important development in sessions. And of course, I'd like to thank all the attendees for listening to us today. And we hope to meet you in the next session. Thank you all. Have a nice day, nice evening.
Thank you very much,
see you all.
Thank you, everyone.
Thank you. Thank you.